Thank you very much for having me here today. So I'm actually going to talk about the training and practice of interventional neurology in Pakistan. And actually, one of my partners, Dr. Suri, who has been very instrumental, is also part of this meeting, and he may be commenting on it as well. So I want to actually talk a little bit about interventional neurology in United States, because that is the template that most countries have used as they have developed their own interventional neurology programs. And when we use the word interventional neurology, I think that it's a subspecialty of neurology that focuses on minimally invasive procedures or catheter-based techniques for treatment of neurological diseases or cerebrovascular diseases. For most part, it has really been endovascular procedures, but I think there is a broader definition of interventional neurology that perhaps includes other minimally invasive procedures such as spine procedures like vertebroplasty and kyphoplasty, and perhaps some of the interventional pain procedures. So I'm actually going to talk a little bit about the training, the certification, the practice, and perhaps some message for the future. Let's talk about training. So in the United States, over the last 20 years, there has been a training pathway that has been established through the American Council of Graduate Medical Education, which pretty much accredits all training programs in the United States. And that actually program is a program that starts once you've finished your neurology residency program. So it is a 3-year path. There is a vascular neurology year, which is really learning how to manage patients with stroke, with some emphasis on neurocritical care. And this is actually a fellowship program that's actually accredited by the American Council of Graduate Medical Education, or ACGME. The next year is actually what we call as the preparatory year. Again, this is supposed to be 1 year. And the purpose of this year is to learn and familiarize yourself with cerebral angiography. So the diagnostic cerebral angiography. There is no accreditation for this year. So there can be a variety of ways you can acquire this year. Some places may allow you to actually do it as being a clinical instructor. Some may actually create it as a fellowship, and some may actually incorporate it in residency programs like in neurosurgery residency programs. And the final year is actually the endovascular surgical neuroradiology year, which is a 1-year program. And this one is actually accredited. And again, this one is to teach how to do interventional therapeutic procedures. And there has been some thought in perhaps actually breaking down the 100 interventional procedures further. And perhaps part of it is driven by the fact that there are certain procedures that are done by more than one specialty. So perhaps actually specifying a certain number of procedures that can be used as a standard for multiple specialties. For example, like carotid angioplasty and stent placement, that is a procedure done by at least 5 different specialties. So perhaps for the hospitals, they need to have some standard where the same standard can be applied to different specialties. And again, various trials have used different criteria of what is a minimum number of procedures that defines the expertise of those participating in clinical trials. And that has actually varied, but however, it's important to know that there is some effort there to actually specify the minimum number of individual procedures beyond the 100 procedures and more defined by the ACGME. And now there is also another pathway, which is the Committee on or the CAS training program, which is actually by the Society of Neurosurgical Surgeon or Neurological Surgeon. This is again similar to mimic what the ACGME pathway is. Again, it's 2-year pathway. And this time the numbers have been specified a little higher. So they are actually saying that you have to do 200 catheter-based diagnostic or interventional procedures and a minimum of 250 neurointerventional procedures. And then again, putting some limit on what those procedures can look like. And they actually have said that there should be a minimum number of procedures, particularly when it comes down to aneurysm treatments, intracranial embolizations, stent placements, and perhaps acute ischemic stroke treatments. And in terms of certification, in United States, there is no such thing as board certification in interventional neurology or any other specialty does the intervention. There is actually a pathway which is called as the focus program destination. This is actually by the American Board of Medical Specialties. So as all of you know that there is a subspecialty certification, for example, in vascular neurology, but that actually requires to have a ACGME accredited fellowship and actually taking a board exam that actually is approved by the board, or the exam is approved by the board. The full focus program designation is somewhat different. It allows you to complete some clinical experience, which is actually predefined. So it doesn't have to be a fellowship or doesn't have to be an accredited fellowship. And there has to be some assessment, which may not necessarily have a board examination as part of it. And the focused pathway or focused practice designation currently requires them to actually be board eligible in neurology and vascular neurology or neurocritical care, have completed a fellowship, which could be accredited by the ACGME or could be accredited by the CAST, or may actually be approved through another pathway. And there is actually another pathway that just got recently approved through the United Councils of Neurological Subspecialty. And then there may be a board examination in addition to an audit of 2 years of procedures that have been performed by the individual who's seeking this designation. So this is what exists in United States today. And then the question was, how do we take this and apply it in Pakistan? And we have had a collaboration with the Pakistan Emirates Military Hospital in Pindi. And this collaboration has been going on for almost 4 years. And as part of the collaboration, we had to start almost de novo. So we had 2 physicians, Lieutenant Colonel Liaquat and Heather, who actually came to University of Missouri. And they spent 6 months here training in interventional procedure. And subsequently, they went back to Pakistan. And then actually Dr. Suri went to Pakistan to provide at-site supervision of this procedure. And also as part of their ongoing accreditation, we do actually provide a continuous review of interventional neurology cases and almost perform an audit. But we did actually have a challenge because eventually the training would have to move back to Pakistan. Pakistan would have to train its own interventional neurologist or neuroradiologist. They would have to come up with their own criteria how to accredit these training programs. And this is actually a proposal that actually has been, or actually is being used at the PEMC or Pakistan Emirates Military Hospital. And that actually anybody has, all people have to complete a residency in neurology or radiology. And then subsequently, it mirrors pretty much what the ACGME requires in the United States. So it actually does have a year of diagnostic angiography. Again, there is no accreditation in Pakistan, so all of these programs are unaccredited, and they may vary depending on the institution that is sponsoring such programs. But the goal again is to do 100 diagnostic angiograms before actually entering the interventional program. And then actually have 1 year or maybe longer, depending on the number of procedures that can be made available. And at least trying to get around 100 neurointerventional procedures in that particular year. And there has been some emphasis to actually provide not just the total number of procedures, but actually provide more details as part of this pathway and actually break down the procedures. So acute stroke interventions give the number of procedures that one has to participate. And that's also specify the minimum number of procedures that are hands-on cases. And I think Dr. Suri will talk more about it. Now, in United States, they actually have the definition, primary operator. And again, obviously, you can be part of more than multiple procedures. You don't have to be primary operator in all the procedures. And then again, similarly with aneurysms, there is a minimum number and also further breakdown into ruptured and unruptured intracranial aneurysms, and actually even further defining the different aspects of the procedure itself and demonstrating proficiency in different aspects of the procedure. And again, flow diverter, which is like stent-like devices that simply divert the flow away from the aneurysms, and even actually getting experience in flow diverters, since seem like they will be actually more and more used in Pakistan as we move forward. And obviously, carotid angioplasty and stent placement, and again, the standard has been maintained very close to what we use in the United States. So again, 25 procedures is what you need in United States, so it's the same that is being applied in Pakistan. Again, also emphasis on different aspects of the procedure as well, to make sure that one is familiar with not just the broader part of the procedure, but the individual aspects or individual components of the procedure. And again, familiarity with different liquid embolic agents and the necessary setup for performing intracranial interventions. And I think that we are fortunate that we have got a lot of support from our collaborators in Pakistan. They haven't asked us to just rubber stamp any training. They've actually asked us to maintain the highest qualities that are required, and they've provided full support as we move forward when defining these standards. A little bit about practice. As I mentioned, that we actually are part of an audit process. So the team that actually performs procedures in the Pakistan Emirates Military Hospital, they do actually provide it with audit of the procedures that have been performed, and they have been able to actually keep very good outcomes as well. So far, since the inception of the program, 51 mechanical thrombectomies have been performed. And as you can see, in terms of techniques, all kinds of devices that we use in the United States have been used. That includes stent retrievers, aspiration catheters, obviously combination of stent retrievers and aspiration catheters, and obviously stent placement, both intracranial and extracranial. And the outcomes actually surprisingly have been very good. So if you look at the rate of intracerebral hemorrhages, it's 8%, which is pretty comparable to what the rates we operate in the United States. And actually, if you look at modified Rankin scale 0 to 2 at 90 days, so this is actually the best outcome you can have in an acute ischemic stroke patient, because it denotes no symptoms, no significant disability or slight disability at 90 days. This is the outcome that has been used in all clinical trials. And in the United States, most people are operating in a margin between 50 and 55%. So actually having that rate around 65% speaks highly of not just the procedural kill, but the post-procedural management as well, because you cannot have good outcome just with procedure alone. You need to have a high standard for the post-procedure care as well. Similarly, the intracranial aneurysm treatment program has also been a success. The patients that have been treated mainly have been patients with ruptured intracranial aneurysms. And again, the techniques are primarily coil placement, but now we are seeing more of stent placement and flow diverter placement as well. So these are perhaps the most advanced techniques we have in the United States as well. They haven't had a single interprocedure rupture, and I compliment them for that, because it wouldn't be, I would have definitely seen more than that if I was doing the procedure, I guess. 2 ischemic stroke, which is perhaps the more common complication with endovascular treatment of aneurysms now. The procedure ruptures have been replaced by ischemic strokes, and essentially intravascular thrombus that can happen pretty frequently. And in all those 4 cases, just the use of terifluran was able to achieve lysis and recanalization. And again, the brain arteriovenous malformation and arteriovenous fistula embolization program has also been successful. And the embolic agents that are used are the ones that are used in the United States. So Onyx obviously is a liquid embolic agent. That's the most common agent used in the United States. And also PHIL, which is actually an agent, a liquid embolic agent that is not available in the United States, but it is available in Pakistan. So that has been used frequently. And the complications are well acceptable complication rates, 3 subarachnoid hemorrhages that were minor. And again, additional procedures are being added to what was being performed. Carotid angioplasty and stent placement has been added, pre-surgical embolization for tumors, and obviously the middle meningeal artery embolization for preventing recurrence with chronic subdural hemorrhages. So that's actually where we are. I just want to leave a few words for the future. I think that we have to recognize the changing face of interventional neurology practice in United States. And obviously that will have implication not just in United States, but globally, and definitely in Pakistan as well. I think the faces of interventionalists will change. People like us who have been doing it for almost 3 decades will perhaps no longer be there for a long period of time. We will be replaced by the new generations, as you can see in these pictures, who are training to do intervention. And it will be the same issue in Pakistan. Procedure that we started with, like endovascular treatment of acute ischemic stroke, is going to increase. Certain procedures are perhaps going to remain the same, like intracranial embolization of aneurysms, carotid angioplasty stent placement, embolization of arteriovenous malformations, dural arteriovenous fistulas, and tumors are perhaps not going to change. The rates will remain the same. Intracranial angioplasty and stent placement obviously has gone down substantially because after the results of the SAMPRIS trial. And for now, we have to actually expect a decrease in these procedures. It is possible with new trials, we may see an increase in these procedures. However, new procedures are being introduced. For example, intra-arterial treatment of headaches and trigeminal neuralgia, treatment of ventricular tachycardias, embolization for chronic subdural hemorrhages, and again, a very exciting field of transepidural approaches where microcatheters are being introduced in the epidural and therapeutic procedures are being performed through those microcatheters and catheter placements. So I'm going to leave the last word here. I think that this is actually more of a philosophical thought, but it does have actually implications for the practice of interventional neurology in general, and obviously the interventional neurology practice in Pakistan. I think we have to look at in a world that is dynamic. Success is highly dependent upon knowing the right time and place for tomorrow, not just today. Well, thank you very much.